This module focuses on understanding spasticity and relevant interventions to treat spasticity in people with MS. Spasticity is a symptom of an upper motor neuron lesion that results in an imbalance between excitatory and inhibitory neuronal circuits. Spasticity has been traditionally defined as velocity-dependent increase in muscle tone. The term spasticity may also refer to hypertonicity with movement or even dystonia at rest. MS-related spasticity is usually the result of increased co-contraction of agonist and antagonist muscles during movement. As many as 80% of persons with MS develop spasticity at some point in the disease course. It is most prevalent in the lower limbs and is associated with increased disability and lower quality of life. Signs and symptoms of spasticity are highly variable among people with MS. As a result, assessment of spasticity must consider multiple aspects of spasticity, including testing of deep tendon reflexes, velocity-dependent increases in stretch reflexes, both passive and active range of motion, the impact on functional mobility, and the patient's subjective perception of spasticity. Spasticity symptoms can also vary day to day or over the course of a single day. The time of day, environmental temperature, stress, pain, and fatigue can all affect spasticity. Increased spasticity may be a sign of other health complications, such as urinary tract infection, so assessment of spasticity must consider the potentially aggravating factors. Spasticity can lead to many secondary effects. Spasticity can increase fatigue due to extra energy expended to overcome tone during voluntary movements. Spasticity can make even simple activities of daily living very challenging. Muscle weakness may occur due to MS lesions and can also be worsened secondary to spasticity if the increased tone impairs voluntary muscle control. Stiffness related to spasticity can lead to decreased range of motion of joints, which results in shortening of muscles and connective tissue around the joints. This, in turn, can lead to contractures. Finally, pain and pressure sores may occur from abnormal positioning caused by the spasticity. On the other hand, spasticity may provide some benefit, so totally eliminating spasticity is not always the goal. Tone can be helpful for standing and transfers if muscles are weak. Because of this caveat, effectively understanding spasticity in each individual you treat will help you optimize their functional abilities. Now, to get to the interventions. The care of subjects with spasticity is complex. Physical therapists utilize many interventions in an effort to reduce spasticity in patients with MS. The evidence for interventions included in this presentation all include subjects with MS. However, there is limited research on spasticity specifically for MS. For intervention planning, research on spasticity and other neurologic conditions, and knowledge of the pathophysiology of MS can help fill in the gaps in MS research. Patients with spasticity should be encouraged to stretch regularly. Stretches are typically held for a minimum of 30 seconds and are ideally performed on a daily basis. Research on subjects with MS found that quadriceps stretching for 2 minutes, 10 minutes, or 30 minutes at a time is beneficial to reduce spasticity as well as increase range of motion. A prolonged stretch of 30 minutes of the hip adductors increased active and passive range of motion after one stretching session. Consistent stretching over several weeks resulted in greater range of motion gains than one single bout of stretching. There is little consensus on the most effective parameters of stretching or even if there is a long-term functional effect. Stretching aims to reduce excitability of stretch reflexes by decreasing force transmitted to muscle spindles, increasing the number of sarcomeres within the muscle, and preventing contractures. If a patient has poor active muscle control, stretching can be done passively by a care partner. In addition, positioning joints with the muscles lengthened will counter the effects of immobilization. More strength and energy is needed to move shortened muscles, so maintaining or increasing range of motion reduces fatigue during voluntary movement. A pilot study evaluated the use of motor imagery and progressive relaxation techniques during passive stretching with the goal of reducing spasticity in subjects with MS, stroke, and brain injury. In the motor imagery group, spasticity did decrease in 4 of 6 subjects compared to 1 of 5 subjects in the progressive relaxation group. The motor imagery technique involved the subject imagining they were actively moving the limb that was being passively stretched by the therapist or care partner. Subjects in the motor imagery group reported less discomfort during stretches and reported voluntarily using the motor imagery technique outside of the clinical setting. Thus, the effects may be attributed to a greater frequency of stretching, in which case motor imagery techniques may improve adherence to a stretching program. Stretches are most effective when performed consistently. Thus, patient education is an important component of spasticity intervention. The National MS Society website has brochures available for persons with MS with instructions on stretching, both alone and with a care partner. The brochures are in PDF format and can be printed from the web. Several anti-spasticity agents are available for spasticity in MS. For focal spasticity, Botox injections are ideal to provide a targeted intervention. Physical therapy is a beneficial adjunct to anti-spasticity drugs. A study comparing the effect of Botox alone compared to Botox and adjunct PT intervention enrolled 38 patients with secondary progressive MS and focal spasticity greater than 3 on the modified Ashworth scale. All subjects received Botox injections in either the upper or lower extremity. 20 subjects also received PT intervention for 15 consecutive days following Botox injections. The 40-minute PT sessions included passive or active exercise and stretching. Both groups demonstrated a significant improvement in spasticity at all points in time. However, the group that received both Botox and the PT intervention had a significantly greater improvement at 4 and 12 weeks post-injection. Additionally, the group that received both Botox and PT also reported significantly greater patient satisfaction regarding the degree of relief from spasticity. Cycling is an intervention used to warm up the body and to maintain range of motion. 2 studies report an effect of leg cycle ergometry on spasticity in subjects with MS. The first study assessed a single bout of lower extremity cycling for 20 minutes. The cycling motion was performed against no resistance. The study results indicate that there's a positive effect on spasticity with the cycling intervention. The 6 subjects had an EDSS less than 5 and were all taking oral baclofen. In the second study of 22 subjects with MS, 2 subjects in the cycling intervention group and 2 in the control group were taking antispasmodic drugs. The main effect in this study was on perception of spasticity as measured by the MS Spasticity Scale 88. The greatest improvement was seen with the walking and pain and discomfort subscales of the MSS 88. The subjective perception of improved spasticity did remain for several weeks following the intervention. There were minimal effects on the soleus H reflex and MAS in the 4-week study. Thus, the immediate improvements for the H reflex and modified Ashworth scale seen with the single bout leg cycle ergometry in the first study may only be a short-term effect or may be dependent on concurrent use of spasticity medications. Based on these studies, cycling exercise as an adjunct to antispasticity medications appears to be effective at reducing spasticity. Ergometers are available for under $40 on Amazon, so it is also a feasible option for home exercise. Cycling with assistance of functional electrical stimulation has been used with neuro patients to increase strength, stimulate aerobic activity, and improve mobility. The FES cycling system allows for a combination of active, passive, and FES-assisted motion. The FES bike system detects the level of volitional movement. The volitional movement is supplemented with either electrical stimulation or the bike has a motor that facilitates passive motion. One study looked at 8 patients with MS that completed 6 FES cycling sessions over 2 weeks. The FES cycling protocol included 12 to 18 minutes of cycling, including 6 minutes of FES-supported cycling. There were significant effects for acute reductions of spasticity immediately after training. The overall effect following the 2-week intervention was a decrease in spasticity as measured by the modified Ashworth scale. The subjects that benefited most were those with higher degrees of disability. Subjective reports included increased independence with ADLs, gait improvements, and increased sensation in the feet. The subjects in this study had limited standing or walking capabilities due to weakness. They were not taking antispasmodic medications, so the weakness is not drug-induced. Use of a standing frame or tilt table for stretching allows use of body weight to provide the stretch force. The ankle plantar flexors, knee flexors, and hip flexors get the greatest benefit from the standing intervention. In addition, standing interventions have multi-system and psychological benefits. A study of 6 patients with MS used a standing frame for 30 minutes a day for 3 weeks. Significant improvements resulted in passive range of motion at the ankle plantar flexors and hips. A non-significant reduction in spasticity was seen at the ankle plantar flexors and knee flexors. 3 of the 6 subjects were not able to tolerate 30 minutes of standing until the 2nd or 3rd week of the intervention. Although speculative, if the intervention period were longer than 3 weeks, it's possible that a significant effect for spasticity may have occurred. Studies on standing interventions in other patient populations show significant improvements in passive range of motion and decreased spasticity. In a single episode of plantar flexion stretching with a standing frame for 30 minutes, patients with spastic hemiplegia demonstrated increased passive dorsiflexion, increased motor neuron excitability of the triceps surae, and increased excitability of the tibialis anterior. In another study, use of a standing frame at least 2 days a week for 30 minutes increased passive dorsiflexion by 3 to 17 degrees for a cohort of ambulatory and non-ambulatory neuro patients. In the clinic, standing frames can be used in conjunction with exercises such as weight shifting, postural education, and upper extremity exercises. Patients also benefit from using a standing frame at home if it is an option financially, but may require assistance to transfer to and from the device. Aquatic therapy can be used to reduce pain and muscle spasm as the warmth of the water encourages muscle relaxation. I Chi is a form of aquatic exercise that has been used to decrease muscle spasm in MS. In an RCT comparing I Chi to land-based relaxation exercise, there was significant effect for the I Chi group in reducing muscle spasm, pain, fatigue, and depression. I Chi is the aquatic version of Tai Chi. The focus of I Chi is to achieve increased range of motion and mobility through exercise and relaxation. I Chi is slow, rhythmic, and fluid, with a strong emphasis on diaphragmatic breathing techniques. It promotes balanced and centered body movements as one foot is planted on the bottom of the pool at all times. Some patients with MS are heat sensitive, but may still tolerate low-intensity activity in water heated to 92 to 96 degrees Fahrenheit. In the I Chi study, the pool was heated to 96.8 degrees Fahrenheit with no heat intolerance reported. However, the MS Society recommends water temperature of 80 to 84 degrees for aquatic exercise. Aquatic exercise may also include walking, range of motion, strengthening, and balance exercises. While warm temperatures may reduce muscle spasm, many persons with MS are unable to tolerate an increase in body temperature. Cooling devices and strategies are commonly used to manage MS symptoms, most commonly to reduce fatigue, but cooling interventions may also have an effect on spasticity. 191 people were interviewed about their MS symptoms. Not all who were surveyed have spasticity, but of the 191 people, 28 reported that they have spasticity and it is affected by temperature. Some believed cooling improved their spasticity, whereas others stated that heat improved their spasticity. Other research has shown mixed results on the use of cooling strategies for spasticity. One study showed a subjective improvement in spasticity, but another showed a short-term increase in spasticity as measured by the modified Ashworth scale. Thus, patients with MS may have varying responses to thermal interventions. Many persons with MS seek complementary and alternative therapies to help manage their symptoms. More than 50% of persons with MS report having tried complementary and alternative therapies, the majority of whom were women. A survey of 138 persons with MS found that subjective benefits related to spasticity were most common with reflexology, massage, yoga, and relaxation and meditation. 77% of survey respondents were women and the median age 45 to 54. There's little evidence to support these therapies, but as PTs we can help direct patients to therapies that are safe and therapies that promote general health and wellness. This concludes the Spasticity Interventions module. Please proceed to the Spasticity post-test and continue to explore the remaining modules that interest you.